thanks for inviting me to speak about the subject I've spent most of my life studying. My initial introduction to this was in my arrival in Lake Tahoe in 1984 after a stint in the Air Force, which was after medical school. Within 3 or 4 months of arrival, I began to see my first case of chronic fatigue syndrome. It seemed to start in the girls' basketball team. It looked like mononucleosis was simply running through these girls, but very shortly after that, their teachers became sick, and very shortly after that, 20% of the teachers in one high school and 30% of the teachers in another high school all became ill over about a 4-month time frame, peaking in about June or July of 1985. By August or so, we had 256 cases in adults, primarily average age 38, coming out of 2 pockets within 2 school systems, one in the Lake Tahoe area and one in Truckee. That started out with what looked like a case of mononucleosis in most instances, although some had more of an encephalitic onset, and some had more of an influenza-like onset, so it wasn't always the same thing, but they all seemed to get some sort of acute viral syndrome. And then after a few months, it began to evolve into something very different than a viral syndrome. And about 6 months into it, Dan Peterson and I kind of looked at each other and said, this thing seemed to have started in the blood, but it's now getting into the central nervous system. We began seeing soft neurologic features, including especially vestibular dysfunction. People would fall over on simple tests of balance. People developed hyperreflexia in the extremities. People developed clonus at the ankles. People suddenly began having trouble getting from one place to another in their cars. They had spatial disruptions and dyscalculia and all kinds of problems of processing information. They would get lost in a one-stop sign town trying to get home. Very odd, and we had never seen anything like this before. There was no experience for this sort of thing. And so we ultimately, I had worked as a graduate assistant at the CDC studying immunology, and so I called him up and I said, you might want to come out here and look at this, because we see it. We have about 250 people, all seem to have gotten the same thing in about a 4 to 6 month time frame, and they're not getting any better. In fact, they're getting worse. And we haven't seen this before. And they said, well, we'll think about it. And a few weeks later, they called back, and little did I know that they were receiving phone calls from all over the nation of physicians seeing exactly the same thing. Except that when they looked at the map, they noticed that we lived in Lake Tahoe, so they decided to make that their first investigation. They would arrive in September of 1985, and they began to look at these patients as we saw them. They saw their atypical lymphocytosis, they saw their swollen glands, they saw their low-grade fever, they saw some of the serology we had done, and they observed that they would fall over on simple tests of vestibular function, and that they had hyperreflexia. And they drew some blood tubes, and then they left town. And didn't hear from them for several months, but what did happen, which was fortuitous, was a reporter from the Sacramento Bee heard that the CDC was investigating a mystery illness in the Lake Tahoe region. So he went out there and interviewed some of these patients and us, and ran an article and went out on the AP line in late September 1985, and the next day, when that AP wire hit the newspapers all over the country, we were getting 50 to 100 phone calls a day from physicians all over the country, having read what was described in the Sacramento Bee article, they were seeing in their hometowns and cities as well. So we realized it was a very strange sensation, because he felt like you had hit some kind of nerve that was ringing throughout the entire nation. And that sort of started the journey that would eventually, I won't drag this out any further, but eventually lead to this podium tonight. So my experience is primarily as a clinician, but I rapidly found out that there wasn't much help out there in terms of either subspecialty care for these people, or even any much knowledge of this disease. So we sort of had to develop our own knowledge of this illness, which is a combination of observation and listening to people for hours and hours and hours over long periods of time, watching them evolve over time, and then working with some very good scientists over the years and other clinicians to get to what we now know about this illness, which I'll present tonight. There are several criteria out there. This is the CDC criteria, Fukuda's definition of 1994. It wasn't the first one. The first one was in 1987. This is a revised edition. It has several major criteria too. In fact, you must meet at least 4 out of 8 minor criteria. There are several exclusion criteria. This has actually served fairly well over the years, although it's been refined by both the Canadians and the Australians and the British. And so, but the purpose of these kinds of case definitions is not to be perfect, but to sort of make sure that everybody is describing the same thing when they study it. So it's an attempt to get everybody on the same page with respect to research. It doesn't really necessarily mean that this is the end-all of the illness. There are certainly people who I think have chronic fatigue syndrome who don't quite meet this definition. And there's some people that sort of meet this definition. I don't think they have chronic fatigue syndrome. So it's certainly not perfect. When you talk to people, I've talked to maybe over 10,000 now, and you listen for this disease, it's a drum roll. You can hear it in their descriptives of it. They talk about their energy is impaired, and it's not just that they're fatigued. There's a dynamic quality to this energy impairment. I would describe it as, well, it isn't so much I have no energy, but if I do something, I'll just crash. I'll collapse. And that collapse of function, this dynamic collapse of function, an hour later or a day later or a week later, it lasts for days and weeks and months. It's really what characterizes this fatigue state. It's a dynamic loss of function. It's not just chronic fatigue. A lot of people with chronic fatigue, once you stimulate them, they don't have chronic fatigue anymore. And then they don't really crash in the days after. These people crash and burn. So it's a dynamic quality, and I listen for that. They also complain significantly of brain dysfunction. And it's not a cortical dysfunction like Alzheimer's is. It's more of a subcortical dysfunction, more aligned to MS and HIV patients. They can't process information very well. So they slow down. They can't sort of figure out what one sensory input needs in respect to some response somewhere else. They can't process in the subcortex. Neuropsychometric testing identifies that this is primarily a subcortical dysfunction, not a cortical dysfunction. They know who they are, they know where they are, they know the president, they recognize people, but they can't process information correctly. And that really is one of the dominant things. I'm listening for that perhaps even more closely than anything else. And if I don't hear any disturbance of cognitive function, I really don't think they have this illness. Pain is very common, but I have patients who do not have any pain at all. They have severe dynamic energy problems and cannot function for that reason, and their brain is shot. And that's really all I really need to hear to think they probably have this. Now, pain can be significant, and sometimes it can be dominant in some of these patients, but as time has gone on, and maybe because of some of the treatments we render, pain doesn't seem to be quite as big a deal today as it was earlier in the course of this illness. I don't know if we're doing a better job of dealing with pain or whether the disease is evolving. So these are some of the cognitive problems seen in 99% of cases. So what happens to the 1%? Well, you have 1% of people say, well, I don't have any cognitive problems. And they don't think they do, but when you test them, they're significantly impacted. When they get to some of these isolated aspects of their subcortical function, there's a wipeout, and they're shocked at what they cannot do. So sometimes they're unaware of this. It's focal and multifocal knockouts of certain processing pathways. Short-term memory is affected auditory more than visual. Sensory and information overload. They have trouble going down the aisles of grocery stores and making decisions about what to purchase or not purchase, or what to put into a cart or what not to put, are completely overwhelmed. Word searching, multitasking problems, and spatial disorganization. There are mood disturbances seen in about 60% of cases. What's interesting to me is that depression is actually not that severe in these people. They seem to be depressed because of the circumstances of their life, not so much because they have some severe internal depression. Although we do see that for some reason it's not the dominant problem in that I see. We see a lot more anxiety disorders in this disease than depression, and some mood lability. Again, there's a symptom dysfunction, which I call the misery component. And then this dynamic problem with an action component, so-called push-crash phenomenon. And there's an evolution of this. These people begin typically with a symptom dysfunction, but they end up primarily with a dynamic functional impairment and actually less misery components. You can see this on this particular chart. You have the misery index over here from low to high, and you have the functional problem from low to high. And in the beginning, in the phase 1 of this illness, you see a lot of misery complaints. I have sore throats, and my glands are swollen, and I ache all over, and I feel absolutely terrible. And yet, they're working. They're actually relatively functional. We saw this in Lake Tahoe dramatically demonstrated. These people trying to work, trying to go to school, feeling absolutely horrible. And that's the early part of the disease. Then it sort of evolves, and they have somewhat less misery and somewhat more dysfunction as they start to complain of things like, I feel like I'm poisoned. I feel something's dreadfully wrong. I can't even put my finger. They search for the adjective to describe how they feel. When they eat, they get worse, and often say things like, I feel best when I don't eat. I feel worse when I do eat. So there's a toxic component that arises that we were curious about, and so did some research on this element, which is sort of midway through their evolution. And then finally, when you see, it's very strange, sometimes the misery index is continuously falling. They don't complain so much of how terrible they feel. They start complaining of what they cannot do. They can't do anything anymore. They're quite impacted. They're homebound or bedbound. Can't do anything. And we're beginning to see evidence of a significant metabolic cardiomyopathy and significant metabolic encephalopathies developed in these patients, which we'll talk about extensively tonight. Because this seems to be the third phase of this illness. There's some belief that there may be DNA epigenetic either adaptations that occurs over time in this disease, or even damage to certain parts of the dark matter DNA, which shows how the codon regions of DNA express themselves. So these people end up with a sort of locked-in state that may be driven by an epigenetic shift that is what may be driving some of this dysfunction. It also makes it incredibly difficult to treat. Does chronic fatigue syndrome have a cellular energy defect? The first indication that there might be a problem with cellular energy is this study that we did in the 90s in Charlotte, and this is using exercise ergometry with gas analysis. You'll notice the controls over here. This is a reference to the percentile of predicted. You notice because they're controls, of which at 25, their oxygen consumption maximum attained at peak exercise sort of oscillates around 100%, which you would expect to see. Down here in the bottom are the couch potatoes. They're healthy otherwise. And at the top are the elite trained athletes. So you can see that to some extent oxygen consumption with exercise can be trained or you can be deconditioned simply by not training. And that's the normal range. You'll notice over in the chronic fatigue syndrome patients, their median is around about two-thirds of normal, about one-third below normal. And although there's a little bit of overlap with some couch potatoes, some of these people are incredibly low. And I always will remember one case, she's actually not plotted on here, but her development of V.02 was simply a flat line. She was pedaling faster and faster and faster and was not using any oxygen at all. Quite incredible. I call her my Martian because she'd do really well on Mars. Another piece of evidence, although I will certainly suggest to you that some people would argue this isn't really an energy problem, they just aren't doing anything. But the Social Security Administration believes that if you study deconditioning, you rarely get below the 85th percentile. So when you fall lower than 85 percentile, you have an organic process. You can't get there simply by being deconditioned. So there's something terrible going on in oxygen utilization and therefore something wrong with their energy production system. Another piece of evidence of energy problems is magnetic resonance spectroscopy. This is work done by the Kumo Shungu at Cornell Law Medical Center in New York City. And we've been sending patients to him for, goodness, a decade now. And he sees evidence of lactate peaks in some of the voxels interrogated. These are small areas of the brain where they can, using inhomogeneity, shifting of the magnetic fields, they can actually focus on very tiny areas of the brain and map the biochemistry with these peaks and valleys. And seeing a lactate peak is not normal. It's certainly not normal at this level. Lactate is produced when the mitochondria are not working. When you lose oxidative phosphorylation, your primary energy producer, you switch over to anaerobic metabolism. And when you do that, you start generating lactic acid. So this was first interesting evidence in the central nervous system, at least, that there was an energy problem at the cell level, and they were generating lactate peaks. We see this, I think in the beginning, the incidence of this was about 70% or so. As time has gone on and they've gotten a little better with both the technology and the algorithms they're using, it's really above 90% now. We see these lactate peaks. In the beginning, back in 2005, Dr. Shungu did a comparative study of normals, people with generalized anxiety disorder, and chronic fatigue syndrome simply by integrating under the curve of the lactate peaks. So these CFS patients have significant lactate elevation, indicating severe disruption of the oxidative phosphorylation system in their brains, loss of energy at the cell level. Kind of interesting in respect to this generalized anxiety disorder patients who have also slight elevation of lactate peak. Is a Harvard professor in the 1930s injected lactic acid into the veins of his medical students. An issue that you'd never be allowed to do today, but he did it back then, and these patients were he was able to reliably induce panic attacks and anxiety disorders by injection of lactic acid. Another way to look at it is that if you're producing lactic acid like this, and you've lost significant oxidative phosphorylation systems, and there's a reduction of oxygen input into the brain, to the brain's eye, that is like being smothered. The brain cell doesn't know why there's no oxygen coming in, and why there's no energy, but it perceives that it's being smothered. And if you ever watched anyone being smothered, it's the most anxiety-producing thing you'll ever do to someone, is to try to smother them. So these people are actually acting like they're being smothered in the central nervous system. This is the most recent publication by Dr. Shungu, and this is published relatively recently, 2012. And they expanded their interrogation of the biochemistry of the brain's chronic fatigue syndrome, and this is what they found. Thus, in exploratory correlation analyses, we found that levels of ventricular lactate, and this is important, and cortical glutathione were inversely correlated with each other and significantly associated with severe key indices of physical health and disability. That is, these lactate peaks, the higher they got, the more disabled they were. And with respect to reduced glutathione, the lower it was, the more disabled they were. He concluded They looked at other things, such as cerebral blood flow. They looked at high-energy phosphate bonds. None of that correlated very well. It was the lactate peaks and the glutathione levels that correlated. So it concludes, collectively, the results of this third independent study support a pathophysiologic model of CFS in which increased, and this is a key idea, we'll explore more, oxidative stress may play a key role in chronic fatigue syndrome etiology. Another phenomenon we've observed for 20 years is these people lose their fingerprints. And not all of them do, but you'll see degradation to varying degrees in the great majority. And probably in about 10, maybe 15%, they really cannot be fingerprinted at all. Probably half of them will have trouble fingerprinting. This is a normal fingerprint, and this is a chronic fatigue syndrome patient. We really got interested in this when some patient came to me and she said her fingers were hurting and it felt like she'd taken her fingers and dipped it in hot oil and then stuck it in a sandbox. And I said, well, give me your fingers. And I looked at them and I couldn't see any fingerprints. And it was then began looking at other fingerprints, and these people are losing their fingerprints. And these people are not old. They're in their 20s and 30s and 40s, and they're doing this. We took 16 of these fingers and we biopsied them, punch biopsies, and sent that to UNC Chapel Hill Dermatopathology Division, and we got the results back, and they were very telling. One defect was they had perilymphocytic vasculitis, which is a signature of immune activation in which their cytokines can be produced that cause lymphocytes to outmigrate into the tissue and cuff the small nutrient vessels. That could affect the skin surfaces because of this. It is seen in lupus, it is seen in other vasculitides, it is seen in chronic fatigue syndrome. But the other thing he saw was even more interesting. They saw punched out lesions in the fibroblasts, which impair collagen formation, and that will impair the ability to hold the fingerprint ret ridges up so they tend to collapse and smooth out. And I asked the pathologist to tell me what diseases cause punched out lesions in the fibroblasts. He said, well, the only thing that seems to do that is scurvy. And I said, scurvy. And then I thought for a minute, well, scurvy is vitamin C deficiency. But what if you simply had severe oxidative stress? Well, you would display the same phenomenon. So these people are not vitamin C deficient, they're under severe oxidative stress, and it's taking their fingerprints. This is one of the biopsies from that time frame. This shows perilymphocytic vasculitis. I lost my slide that showed punched out lesions. And that brings me to sort of a model that's been developed based upon some of those earlier slides I showed you. Don't concentrate on the red part, just concentrate on the white part. You have the mitochondria, and of course, red cells carry oxygen in the bloodstream, and then the oxygen is translated into the mitochondria to help you make ATP, which is the primary energy source in this rather impressive oxidative phosphorylation system we call mitochondria. There's an interesting feedback loop. It's right in here, where from this oxygen you generate energy, then you couple that energy into systems, which is magnesium-dependent process, which, by the way, is one of the big deals in chronic fatigue syndrome. Magnesium is wonderful for these patients. It's probably the simplest, safest, best thing I've ever used to treat energy problems in this disease. But tablets don't work. Tablets are ineffective. You have to I have to put it on your skin through a cream, you have to squirt it on your tongue, or you have to inject it. And you don't need very much for this. But you'll notice that the magnesium couples ATP to ADP. So in effect, it's sort of like taking your foot off the clutch. You're making the same amount of energy, but when you take the foot off the clutch, the car actually moves. The same is true here. You're not making more energy with magnesium, you're actually coupling it. It's coupled into ADP, and then from there in AMP, and this actually is a feedback loop for oxygen transfer, which means that if you're not coupling ATP to ADP, there will be no oxygen transfer into the system. It's a feedback lock-loop system. If you look at the textbook of physiology, you'll notice that oxygen transfer into the cell is primarily determined by ADP levels. If they're low, there will be no oxygen transfer. That's an important idea. Of course, when you make ATP, you also make superoxide. And that's a conundrum, an energy conundrum. You cannot make energy without making oxidative stress in the form of superoxide. The body knows this, of course, and it's developed a fantastic redox cooling system composed of several different enzymes, SOD, GPX, and catalase. And these are the kinetic speeds of these enzymes. These are the fastest enzyme systems in the human body. They're incredibly speedy, and they have to be that way because if they fail to take superoxide down to water, which is their job, then you cannot make energy. Because if you do, you're just going to fry the mitochondrial membrane, because if this superoxide is not taken first to hydrogen peroxide, and then from there to water by two different pathways, then the superoxide will turn into free radicals. It will react with nitric oxide and form so-called oxynitrate, which is called the no hypothesis of Marty Paul, which some of you may have heard or read about, or it back reacts with hydrogen peroxide to form hydroxy radical. This impressive production of these free radicals will actually destroy the membrane of the intermitochondrial membrane and bring energy production to a halt. The reason you do this is to save yourself, because if you continue to generate energy when you cannot cool the system, then you have to bring down energy to save your life, and that is, we think, is exactly what's going on. In other words, the energy downregulation is not the problem. The energy downregulation is the solution to prevent a deeper problem. And so the problem is something's wrong with this redox cooling system. Studies on some of these elements, SOD and GPX and catalase, as well as, here we go, reduced glutathione, I mentioned that with Schumber's paper, and NADPH, an important reducing energy substance made in the liver. There's something wrong with this system, and you can see it and prove it and measure it in every single patient. It's there if you just look for it. If you have a defect in redox cooling, then there will be increased oxidative stress, and if you're lucky, that will feedback loop inhibit the mitochondria from producing energy, and then you'll equilibrate at a lower energy state to save your life. It doesn't mean that the low energy state is pleasant. It doesn't mean that there aren't complications from that, but your life is preserved. And that brings me to one of the interesting phenomena of this disease. I've watched these patients for 25 years, and they simply, as a group, don't die that much. They go on and on and on. They fade away, to be sure, but they're not dropping dead like flies. As a matter of fact, I'm an internal medicine doctor, and if you ask internists my age, how many of your patients are left after 30 years? And the answer is only about half are left. Why? Because you only see an internist if you have significant illness, and in 30 years, half of them, well, I'm not anywhere near that number have died in my hands. And so there's something preserving these patients, and what's preserved is that they're equilibrating to a low energy state to prevent some sort of disease progression, but they're locked in. So what is the evidence for some of this? This was performed at the cell biology department at UNC Chapel Hill, believe it or not, in 1992, because the chairman of that department's daughter had this syndrome, and he called me up and said, "Is there anything I can do to help you?" I was in Charlotte at the time, and I said, "Yes. Do you do any kind of energy measurements?" I said, "Well, that's what we do here." And I said, "Well, how do you do it?" We use fluorescent tags of the intermitochondrial membrane, and the intensity of the fluorescence is related to the degree of energy production. So the higher energy being produced, the brighter the intensity, and the lower energy being produced, in the mitochondria, the lower the intensity of the fluorescence. What you're seeing here are white cells plated on they're basically they're plated on a glass plate to which they adhere, and then they stain these lymphocytes. They're plated on a plate, and then they look at them with a confocal microscope that's focused right on this plate, and then they stain them with these fluorescent dyes, and then they take up the dye in direct proportion to how much energy is being produced. And when he did this, he called me back and said, "It's really quite shocking. Your patients don't have any energy in their lymphocytes." I said, "Well, wow, that's a big shock. They don't have any energy. They don't sound like they do either." This was, unfortunately, they applied for a grant to do this work, and of course, because the grant was entitled to study mitochondria and chronic fatigue syndrome, it was promptly denied by the NIH. But about 20 years later, Robert Nicholson did pretty much identical experiment using, again, fluorescent dyes on mitochondria, compared controls to chronic fatigue syndrome. They are significantly downregulated in regard to oxidative phosphorylation and energy production. Another investigator in the UK, Dr. John McLaren Howard, using layered polarization fluorescent imaging, was able to look at the plasma membranes of peripheral mononuclear cells and found, guess what, oxidative damage to the plasma membrane, as identified by these arrows, showing various kinds of oxidative changes of light areas, certain kind of what appear to be microbial damage, elongated fatty acids, and unusual lipid binding. There's oxidative stress going on, which is damaging the membrane. If that damage occurs in the inner mitochondrial membrane, will downregulate energy production, fitting the model. Looking at other areas, he found problems with disordered fatty acid structures. And this finding of oxidative damage to important membranes has led some people to treat this in various lipid therapies. And Dr. Patricia Kane in New Jersey is probably the best person in the world right now working in this area. And she does get benefits from lipid therapy. The problem is that we don't think the problem is lipids per se. They're just being hit by oxidative stress. The problem is failure to cool off superoxide production by this cooling system. The point there being, if you don't fix that, then by simply repairing the membrane, you just increase energy production and increase oxidative stress in the system. So I don't think it's going to go very far until they come in on the real problem, which is containment of oxidative stress. Is there CFS-associated cardiomyopathy? Yes, there is. If you want to talk about cardiomyopathy in its most general form, some sort of metabolic disturbance of the heart. And that requires a conceptual breakthrough in what it means, what is meant by diastolic function and systolic function. In the case of systolic function, there's an EKG signal causing depolarization, calcium influxes, and causes myofibril contraction and the heart squeezes. In diastolic dysfunction, ATP is required to pump out the calcium into the sarcoplasmic reticulum, causing myofibril relaxation, and the heart fills with blood. You'll notice this is not intuitive. It means that energy production is used to relax the heart, not to squeeze the heart. So when the heart is squeezing, you're not consuming energy, you're actually releasing energy that was already put into the heart while it was relaxing. This is an analogy, I'm trying to think here's an analogy. A dam worker arrives at the base of the Hoover Dam. He walks to a console and he presses a button and opens a gate. And the water comes out of the base of the Hoover Dam and lights Las Vegas. He just took his little finger and he pushed the button and he lit Las Vegas. You would think if you were from outer space, well, that maybe there was some energy in his finger. No. The energy was already pumped into Lake Mead over decades before, and that is what's driving. All he did was release the energy. Likewise, in diastolic function, you're actually pumping energy into the system to provoke, get this, relaxation by pumping all the calcium out. As you do that, the heart fills with blood, and then the EKG signal just releases the energy that's been pumped in, and the heart squeezes. So it's not, the squeeze isn't where the energy entered the system. The energy system entered in the filling action. And that's very important because if we look at the heart from an energy perspective, you do not look at the squeeze. You look at the fill. And that's an important idea. The first person to actually investigate whether there actually was evidence of an energy defect in chronic fatigue syndrome is Hollingsworth. Hollingsworth is an investigator in the UK using, guess what, MRSI, this time of the heart as opposed to MRSI of the brain. And he showed that there was cardiac myoenergetic abnormalities were a feature of CFS with lowered phosphate-creatine to ATP ratios compared to healthy controls. 1.76 for CFS as a group versus 1.9 for controls. But that a subgroup of CF cases comprising, get this, 1/3 of these patients were in the cardiomyopathic range with an average ratio of 1.57. And if you look in cardiology textbooks, when you're at 1.57, you're not going to survive that. That is lethal. These people are all dead in 5 years at that level. So our patients have an energy level equal to people with heart disease that would kill them, and ours don't die. And the reason for that is our patients' systolic function is maintained. In other heart diseases that we have this problem, their systolic function is not maintained, and that is the difference. This correlates in my practice, where 1/3 of my patients have a cardiac index in the cardiogenic shock range of 1.8. Furthermore, MRSI supports the pure energy deficit hypothesis for diastolic dysfunction in chronic fatigue syndrome. My first introduction to problems with the heart was from a Peckerman paper published in 2003 in the American Journal of Medical Sciences. Using impedance cardiography, he looked at controls in white and noticed that when they were lying down, they had an average output of 7 liters per minute, and when they stood up, they dropped to about 5 liters per minute. That's normal. You'll notice that even in normal people, when you stand up, you lose 30% of your cardiac output. That's normal. In the case of chronic fatigue syndrome, when they're supine, they're at about 5.5 liters per minute. And when they stand up, they go down to 3.7. And what's interesting about this is that you are effectively in cardiogenic shock when you drop below about 4. So when they stand up, they're not being perfused very well. And that's one of the reasons these patients have significant problems standing. They don't like to stand. If they do stand, they have to move around. If they stand for long, they have to sit down or lay down or fall down. That's because if you have this kind of drop when you stand, you drop them below a certain threshold, and it's not tolerated. So one of the features of diastolic dysfunction is orthostatic intolerance. They don't like standing, which is interestingly almost the opposite of systolic failure, where they don't like lying flat. They do better sitting up. Our patient's the exact opposite. They don't like standing up, they like lying down, because they don't have systolic dysfunction, they have diastolic dysfunction, because they have an energy defect at the cell level. I repeated this experiment because when I first saw it, I didn't believe it because I didn't think there was anything wrong with the hearts of chronic fatigue syndrome. I was an expert, right, so I knew there wasn't any problem with these patients' hearts. When I saw this, I was pretty shocked, and I redid this experiment in my clinic to prove them wrong. In fact, my patients were sicker than that recorded in the literature. And because what's peculiarity about my practice is that when people are studied by academics, they're not very sick because academics don't treat anybody. So they come to people like me who will be able to treat them. So I see all the sick people. So what we see is a lot different than what the academics tend to see. So with respect to this data, I was pretty shocked about this because I didn't know why Peckerman never asked the question that should have been asked: why do they have low cardiac output? By the way, he also showed that they is correlated with disability. That is, the lower the output was, the more disabled they were, and the higher the output was, the less disabled they were. So there was significant correlation to this. And I thought that was important to know, and I said, well, why do they have low cardiac output? So I ordered 3 of the patients who scored the lowest and below on this, and I had them echoed in 3 different centers around the nation where they lived, and the echoes all arrived at my desk at the same time, and they all said the same thing. They said, normal wall thickness, normal chamber size, normal valve function, normal everything, except, type 1 diastolic dysfunction noted. They all said the same thing, that last sentence, type 1 diastolic dysfunction noted, but everything else is normal. And so I was shocked because I didn't know what that meant, and I was embarrassed because I went to Emory. I'm supposed to know everything about the heart. I didn't know what it meant. So I called up a friend of mine I went to school with, and I said, Dick, first of all, why don't I know what that means? And he said, well, that's a new term, and it didn't exist when you and I were in school. I said, well, it's a new term. You mean this is something about the heart that no one even knew existed? He said, yeah, until about 10 years ago, it did not exist. Well, it actually does exist, and is a significant feature of chronic fatigue syndrome. Almost all of them have this. So I said, well, that explains why I didn't know what it is. So would you tell me what it means? And he said, that's what the heart looks like when there's no energy in it at the cell level. And I was shocked, and I asked if he would allow me to repeat what he just said back to him. I said, do you mean that an energy defect at the cell level would manifest as diastolic dysfunction? He said, yes, absolutely. And I said, would it drop the cardiac output? And he said, you betcha, especially when they stand up. And you get gravity filling problems on top of underlying energy filling problems. So I knew I was onto something, so I asked him, well, how do I measure this? He said, well, you need to get a really good echo machine, one of the tissue Doppler capacities, and sufficient power. And I said, well, what would you recommend? He said, the Vivid 7, I'll get that, made by GE. So I called up GE and had them demo this big machine in my offices, and they brought it in 3 different boxes. And 2 sonographers flew up from Orlando, and they echoed 6 of my patients in a row, and this was in early 2005. And after they finished, the echo sonographer turned to me and he said, Dr. Cheney, we have never seen this before. They all have diastolic dysfunction, and they're relatively young. And I said, well, that's interesting. Well, why do you seem so surprised? He said, well, we've never seen this before in such young people. Could you tell me what they have? And I said, they have chronic fatigue syndrome. And then he said, what's that? So clearly, no one had even looked at this. So I decided to get a grant and got this machine, and I've been doing echocardiography ever since. And it's been quite a bit of journey because there's not a lot of help in the cardiology community because they see diastolic dysfunction as an old person's disease, or it's related to underlying conditions like diabetes or hypertension. And none of my patients have any of that. They're not old, they're not diabetic, and they're not hypertensive. So it doesn't really click the cardiologist that there might be such a thing as a pure energy deficit. Otherwise, the heart is completely normal. That's a good thing, because with a normal heart, you can compensate for diastolic dysfunction. And it turns out the major compensation mechanism is to squeeze your ventricles as hard as you can. So you see high ejection fractions in these people. We call it cavitation. The ventricle squeezes really, really hard. And that creates several complications that we'll get into. And I simply note that it's not just that they have diastolic dysfunction, it's they have maintained systolic function, and they use the systolic function to compensate. As a result, if you squeeze hard enough, you can fire the C fiber, causing neurally mediated hypotension, and you'll pass out and hit the floor. That was reported at Johns Hopkins back in the 90s, that about a certain percentage of these patients have NMH or POTS or difficulty standing, which they blamed on autonomic dysfunction. It has absolutely nothing to do with autonomic dysfunction. They have diastolic dysfunction, and it's not good for them to stand up. Partly because they have good systolic function. This is an example of the cardiac output measured by echo. And here you put the transducer in the pulse mode, and you put it right at the aortic outflow tract, and you'll see this time velocity development in the aortic channel. And this is basically the aortic valve opens and the blood starts rushing out, reaches a peak velocity, and then comes back to zero as the aortic valve shuts. If you integrate this with your little mouse and your finger, that generates the stroke volume, which you see over here, LV stroke volume, 124 cc's. That's a normal stroke volume. If you then take the mouse button and put it at the head of the next opening, that gives you your heart rate. Heart rate times stroke volume equals the cardiac output, which is 8.3 liters per minute. If you divide by the size of the person, that'll give you the cardiac index in square meters, or size in square meters. And then we began to look at the cardiac index in my patient population using this methodology. And this is what we got. Here's chronic fatigue syndrome. The normal range for cardiac index is between 3 and 3.5. Tends to be a little higher in younger people, closer to 3 in older people. And these are all the diseases associated with either an elevated cardiac index or depressed cardiac index. My patients average about 2.36. 30% of them are less than 1.8. 30% of them are in the cardiogenic shock range, which was also matched by Hollingsworth identification of this very low phosphocreatinine to ATP ratio. So, on average, our patients lie somewhere between mild shock and traumatic shock. This is, to me, absolutely incredible. They have a lower cardiac output than people that have myocardial infarction. And this output correlates with disability. The lower that thing is, the more disabled they are. The higher that is, the less disabled. Exactly what was described by Perrin. Notice some of the things that produce high outputs: hyperthyroidism, anxiety disorders, pulmonary disease, hypertension tend to be high. Myocardial infarction is low, mild shock is low, chronic fatigue syndrome is lower, traumatic shock is lower, and finally cardiogenic shock, which is the end of the road, is the lowest, where 1/3 of my patients sit. This is some of the data on stroke volume. This is a case control study, 15 age and sex matched cases against 15 patients. High degree of difference. The average stroke volume in the control population, age and sex match, was about 80. Our patients are sitting at about 60 cc's. This is some of the diastolic parameters that we look at. And over the years, I've really looked at this a lot. And of course, you see different percentages of patients meet certain criteria for diastolic dysfunction. What's important is they also compensate for diastolic dysfunction by big left ventricular squeezes. So one of the aspects of that big squeeze is that when it relaxes, it actually sucks blood in. And that actually helps you fill the heart, not by relaxation mechanism particularly, but by simply a rebound off that big squeeze. And so this compensation mechanism turns out to be really the thing to look at, not so much whether they have diastolic dysfunction or whether they don't, because it can be masked off by these compensatory mechanisms. But anyway, this is the early fill and the late fill by atrial kick of a normal person. You'll notice the E wave is bigger than the A wave. Think of this as E is for energy, A is for atrium. E is actually stands for early filling, and that's due to the early relaxation of the myocardium, energy dependent. Then the atrial kick tops off the left ventricle as it squeezes, giving you a little bit more kick into the left ventricle to fill it, F-I-L-L. In type 1 dysfunction, the E is lost and the A decreases because one of the early compensatory mechanisms of lack of filling energetically is for your left atrium to squeeze harder. If it squeezes a lot harder for a long time, it starts to dilate. And dilation of the left atrium is one of the early morphologic features of diastolic dysfunction. At the end of the road, you get this type 2 diastolic dysfunction, very high E wave due to lack of compliance in the left ventricle. And look here, your atrium is dying, so it can't give you much of a kick anymore. This has a 75% 5-year death rate. I have never seen this in chronic fatigue syndrome. Cardiologists see this all the time. I don't. I see either this one or this one. Looking at tissue development, which is more a little more sensitive to diastolic dysfunction, you're looking at movement of the movement of tissue rather than blood flow. You see the E prime, which corresponds to the E wave, and the A prime, which corresponds to the A wave, because the tissue is moving in the opposite direction of blood flow. It's reversed. This is normal. In chronic fatigue syndrome, you see the E prime is lost and the A prime expands. That's consistent with diastolic dysfunction, sometimes known as pseudo-normal type in the literature. My favorite is pulmonary vein interrogation, where you shoot all the way through the heart, all the way to the entry point where the pulmonary veins are coming back into the left atrium. You put it there, you see in normal people an S wave, which is the right ventricle squeezing, filling the left atrium with that right ventricular squeeze. Then you get the D wave, which is the early filling when the left ventricle is starting to relax in its energy phase and blood's moving out of the lung across that pulmonary vein, creating the so-called D wave for diastology. Here's the A wave squeeze. Since the atrium squeezing, some of that blood goes back up into the pulmonary vein, therefore it goes in the opposite direction. And that's normal. In chronic fatigue syndrome, you see this. You see a huge S wave. That's because they have normal systolic function and they have hypersystolic function, and they're using it to fill the left side with it. They're using it as compensation. People with heart disease don't have this so much because they don't have enough squeeze to do that. So we see this big S wave, this small D wave, and this sort of widened A wave. This is the most sensitive indicator of diastolic dysfunction in chronic fatigue syndrome because it captures two things the others don't capture. It captures the E to A reversal, but it also captures, even more importantly, the systolic squeeze or systolic compensation, which we'll get into in terms of the major complications of this illness. So it looks like in real time. This is a normal person. Here's the E wave and early filling, late atrial kick filling. This is chronic fatigue syndrome. This is the early E filling and the big atrial squeeze to compensate. This is diastolic dysfunction. I see this in roughly 40% of my cases. It tends to be more obvious in the older crowd, less often seen in the younger crowd because they compensate better. This is tissue Doppler. This is normal over here. This is early fill, late fill squeeze out through the aorta. Early fill, late fill. You notice the early fill is big, the late fill is small. It's reversed in chronic fatigue syndrome with a lower early fill and a bigger atrial kick, seen on tissue Doppler. This is seen in 60% of our cases. This is the pulmonary vein interrogation. This is normal. You get a little bit of S wave. This big D wave filling component. The A wave is down here. That's normal. In CFS, you see the opposite: big S wave, little D wave, and a widened A wave. I see this in 97% of chronic fatigue syndrome because it captures the systolic compensation that is otherwise missed if you just concentrate on the classical diastolic indicators. This is some of the data on 70 patients, and you'll see this DS reversal 96%, one or more in 97%. This is a left atrial cavitation. When you stand them up, they not only can't fill to begin with, FILL, but when you stand them up, they get gravity filling problems too. And interestingly, the heart actually collapses in size so much that if you x-ray them in the upright position, the Japanese did this, you notice that the cardiac silhouette was extremely narrow. So they published a paper called Small Heart Syndrome. The reason it's small is not because it's small, but when they stand up, all the blood drains out of it. It just collapses because the blood drains out of it. And you can see the left atrium right here, and when they stand up on 70 head up tilt, look at this left atrium. It just pancakes. It just pancakes. Normal people do not do this. No normal person does this. And it's one of the characteristic features of head up tilt. They simply their blood slowly rolls out of the cardiac silhouette. The implications of this are pretty phenomenal because if you collapse the left atrium, there's a little valve that is open when you're in utero called the foramen ovale. And when in the first year of life, when you first are born, that valve shuts in the first year of life. It typically will seal. We call that a foramen ovale. And 70-odd% of us seal that in the first year of life. So about 20% of us don't. We call that a patent foramen ovale. We'll show this in a minute, but almost all of my patients have a hole in their heart right here. Their patent foramen ovale is blown completely open. And the reason it's blown open is because if you collapse the left atrium, there's no pressure in it. If there's no pressure in it, it's like a beer can. If you pull the air out of it, the beer can just collapses, so the right side will blow right through the sealed foramen ovale and open it wide open. And we'll show pictures of that. The importance of this is the most common complication of patent foramen ovale is migraine headache. Another complication is many strokes, which produce unidentified bright objects on the MRI scans of these patients, which we see all the time. And another problem of PFO is you better not decide to climb to high altitudes, because in high altitudes you can shunt across and get into serious trouble. Maybe the cause of sudden death at high altitude climbing of these PFOs. So some of our patients have a real hard time in airplanes because of this. And this is the LV squeeze. This is normal. You can see during diastole when the ventricle is sort of relaxed, you notice this interventricular septum is pretty small. It's only about 8.5 millimeters. And then when they squeeze, these interventricular septum, which is part of the ventricular wall, squeezes up from 8 to 10 millimeters. That's what normal looks like. This is what chronic fatigue syndrome patients look like. In the diastolic position, they're not much different than normal people. But when they squeeze, look what happens. They go not from 8 to maybe 10 or 12, they go to 15. I've seen them go all the way to 24 millimeters. They squeeze the living hell out of the left ventricle. And this ventricle, it's real thick. And that may be the cause of some of the chest pain they have from subendocardial ischemia from this big squeeze. And it has a significant complication that I'll get into later. So this is some of the summary of some of these phenomena that we've observed. This is, I'm going to slide through this and take a break. This is the use of a type of technology where we can see the movement of 400 little places on the left ventricle and look to see if there's dysynchronization of the left ventricle. And you see that all the time in these patients. This is normal synchronization, where different parts of the ventricle correspond to different colors. And you'll notice they're all moving in synchrony. The early fill, the late fill, and the systolic ejection. The early fill, the late, everything in the ventricle is moving at the same time in synchrony. This is what chronic fatigue syndrome patients look like. They're completely dysynchronized, which is really going to just kill their cardiac output. But one of the interesting treatments for this, and it's a very good treatment, is magnesium. This just shows positive strain patterns, which is probably over-squeezing of the left ventricle in an attempt to compensate for poor filling.